Perfect. Uh, so my topic today is on procalcitonin. The reason I chose this topic is that procalcitonin as a marker for infection has been used more and more by clinicians, and something that we should be more familiar with. So I'm here to provide a little background, a brief overview. I'm going to talk a little bit about the assay, including some of the reference ranges that clinicians are using, as well as some of the kinetics. Of course, I'll mention its limitations, which there is a few of, and its use in various clinical settings, as well as some of the literature out there, real briefly. So, a little introduction. The interest in biomarkers that discriminate between infectious and non-infectious cause of fever has grown. For infectious causes, the need to identify a bacterial etiology is of great importance, as we all know, is that requires antibiotic therapy with bacterial infections. Severity has been used clinically for over 90 years, and CRP has been used routinely for 30 years as a marker to assist with the management of infections. But along with a lot of limitations, another one includes that they are both non-specific. New markers have been sought after that are more sensitive and specific to differentiate between bacterial or other infections such as viral fungal, which can be utilized as diagnostic and prognostic tools in the care of patients with severe infections and have been sought after. And this again has been sought after, and a promising marker is procalcitonin. So a little bit about the history. In 1983, this is when it was first identified to uh, first noticed to have increased levels of serum procalcitonin in toxic shock syndrome. It was later also reported to have elevated levels in the setting of sepsis. Over the past decade, there's been a large number of publications concerning procalcitonin as a serum marker for SIRS, or systemic inflammatory response syndrome, infection, and sepsis. Procalcitonin has been found to increase greatly with bacterial infections. Some studies report having a sensitivity of 97% and a specificity of 78% for differentiating patients with SIRS from those with sepsis. Levels of procalcitonin have been found to correlate with the severity of the infection, i.e., higher levels of serum procalcitonin concentrations correlates with a more severe infection and septic shock. Studies implementing algorithms based on serial procalcitonin for severe infections have shown to lower the duration of antibiotics, something we deal with in stewardship. And as we know, by decreasing the duration of antibiotics, we can decrease antibiotic associated adverse events, risk of developing resistance, and treatment costs. So, a little background. Procalcitonin is a 116 amino acid protein, and it is a procalcitonin, prohormone of calcitonin. Unlike calcitonin, which is produced exclusively in C cells of the thyroid gland, procalcitonin is secreted from all parenchymal tissue in response to pro-inflammatory situations, particularly bacterial infections. And when these infections occur, and thought to be due to the endotoxin from the bacteria and the cytokine inflammatory response, it induces an increase in the calc1 gene expression, which stimulates the release of procalcitonin. After again the stimulus, procalcitonin levels rise within 2 to 3 hours. Levels have a tendency to rise rapidly, reaching a plateau after 6 to 12 hours. Levels remain high for up to 48 hours, and then return to baseline approximately 2 days afterwards. The recovery of treatment of the underlying disease with the recovery or treatment of the underlying disease, the procalcitonin levels decrease, indicating a positive prognosis. High or further increasing levels indicate a poor prognosis, as some of these studies have showed, and obviously there are some exceptions, obviously, to these rules. Procalcitonin does have a half-life of approximately 20 to 24 hours. This is from the manufacturer of Procalcitonin Assay website. This was a 76-year-old female who was accidentally given a solution contaminated with Acinetobacter. They measured serial they measured serial procalcitonin concentrations, and sort of demonstrate its kinetics in that procalcitonin does have a tendency to rise at a slower rate in the induction phase or the initial phase of zero point 0.5 nanograms per milliliter per hour, following a 2 to 3 hour latency period, with 3 hours the first time you see elevations in procalcitonin. And then following the induction phase, there's a rapid peak, rapid increase of at a rate of 50.6 nanograms per milliliter per hour. It peaks and plateaus and then steadily declines afterwards. So a little of the hormone itself, procalcitonin, is cleaved enzymatically into free amino procalcitonin, and the conjoined calcitonin, calcitonin carboxypeptide 1, which is then processed into free CCP1, an immature calcitonin, which ultimately matures into a mature calcitonin. All these peptides are found in the serum of normal persons at extremely low levels of less than 0.05 nanograms per milliliter. But again, in the setting of sepsis, with the exception of mature calcitonin, all the previous precursors, these peptides, are increased to a marked extent. So what you might ask, what is the role, physiologically, the role of procalcitonin in the setting of sepsis? The role is largely unknown. It has been suggested that procalcitonin increases mortality and morbidity in the critically ill. Procalcitonin is thought to carry leukocyte chemoattractant properties and modulate the production of nitrous oxide by the endothelial cells. So animal testing has demonstrated the increase of mortality and morbidity in procalcitonin. So in animal studies where in a normal animal host procalcitonin is administered, there was only minor changes in glucose, calcium, and phosphate, but no obvious deleterious effects or mortality noted in this small animal study. In contrast, when procalcitonin was given in infected animals with increased baseline procalcitonin, the mortality rates of those animals were approached close to 100%. In another animal study, immunoneutralization by anti-serum targeting procalcitonin was found to ameliorate the symptoms and also improve the survival of severely infected animals. Just keeping this in mind that it may offer a new therapeutic possibilities in our septic patients. So a little bit about the assay. There's no clear-cut assay that detects the procalcitonin peptide exclusively. Depending on the type of assay, all tests detect various portions of the several calcitonin precursors. Because procalcitonin is always increased when the other precursors are increased, for simplicity of expression, the assay has always been referred to by investigators as just a procalcitonin assay. So one of the most commonly used assays in the studies was the insensitive and immunoaluminometric procalcitonin assay, called the LUMI test by the Brahms company. Newer assays have been found to be a little bit more sensitive. The assays we use at both the VA and Tampa General appears to be the Vitus Brahms procalcitonin assay using the enzyme-linked fluorescent assay technique, which again is found to be more sensitive. They also incorporate in part of the assay a monoclonal antibody against anti-human procalcitonin. And according to the manufacturer, depending on the clinical situation, procalcitonin concentrations of greater than 0.1 nanograms per milliliter can indicate a clinically relevant bacterial infection, which is lower than previous assays, which recommend the cutoff be at 0.5 to 2 even. This table illustrates some of the assays that are available from a 2008 article, so it does not include the Vitus testing that we have now. The first, again, the LUMI test being the most widely assay used in the studies and worldwide. All other options include the Pro-CAS, the procalcitonin sensitive, the Q-procalcitonin, and the N-procalcitonin. Of note, the scriptor for the Brahms company is what some people classify as the second generation, again with better sensitivities and specificities. One thing I can delineate was that if the Vitus that both the VA and Tampa General uses did have the procalcitonin exclusively or with precursor in conjunction. The optimal cutoff ranges of the procalcitonin is variable and dependent on a multitude of situations. The clinical setting, whether the patient is in the emergency room, ICU, post-operative setting, or trauma patients, the site and extent of the infection, comorbidities including immunosuppression, as well as the clinical indications and implications of in diagnosis, prognosis, and antibiotic stewardship. A point that I'll stress once again is clinicians should use procalcitonin results in conjunction with other laboratory findings and clinical signs of the patient and interpret the values in the context with this clinical situation. This table shows a proposed cutoff ranges of procalcitonin, again using more the older Lumi test assay. This was proposed by the American College of Chest Physicians and the Society of Critical Care Medicine. So just going through each cutoff range at less than 0.5 nanograms per milliliter. They categorize this as a systemic infection is not likely, keeping in mind that local bacterial infection is possible. Early in the course of severe bacterial infections of usually less than 6 hours can also have low levels initially. The next range, the 0.5 to 2, some people categorize this as the indeterminate range, and says that there is a moderate risk of progression to severe sepsis. The governing bodies recommended monitoring closely both clinically and by serial procalcitonin to be recessed at different time intervals. At levels of procalcitonin of 2 to 10, there's a high risk of progression to severe sepsis, and at levels of greater than 10, there's a high likelihood of severe sepsis or septic shock. So outside of bacterial infection, there are other things that can cause elevations in procalcitonin levels, something we should be aware of. And there's numerous case scenarios, as I list below. Neonates of less than 48 hours due to physiological elevations, first days of major trauma, major surgical intervention, severe burns, and treatment with OKT3 antibodies and other drugs stimulating the release of pro-inflammatory cytokines. Invasive fungal infections and malaria, prolonged or severe cardiogenic shock, prolonged severe organ perfusion or abnormalities, malignancies including medullary C-cell carcinoma of the thyroid, neuroendocrine tumors, small cell lung CA, as well as carcinoid tumors. Other things include inhalation injury, pulmonary aspiration or pneumonitis, obstructive pancreatitis, as well as heat stroke. There are no significant elevations of procalcitonin seen with the following, which may present a little superiority to the previous inflammatory markers such as SED rates and CRPs, include viral infection, allergic reactions, autoimmune disease, and graft rejection. Also of note that the procalcitonin concentrations are not affected by renal functions. With that being said, low procalcitonin levels does not always indicate the absence of bacterial infection. Again, early in the course of infection, usually less than 6 hours. If still suspected, again, the authors recommended to reassess at 6 to 24 hours later, either both clinically and by serial procalcitonin levels. Localized infections and infectious endocarditis. So next I'm going to look at different clinical situations and where procalcitonin may have some benefit. The first one, systemic inflammation without infection. Number of clinical scenarios with hyperprocalcitonemia in the absence of a bacterial infections have been noted. There's a condition, it is thought that that these conditions are accompanied by transient translocation of the lipopolysaccharide or other bacterial products from the gut to the systemic circulation, which can account for the elevations of the procalcitonin concentration. Mechanical trauma involving the head, trunk, abdomen, or limbs is the most common cause of elevated protein of procalcitonin without an infection. And procalcitonin does appear to correlate, according to the studies, to the extent of the injury, the extent of surgical procedure, or the severity of their burns. This graph shows a peak fold increase, and I'm not sure if you can see it well. Concentrations in 4 healthy volunteers that was given endotoxin at increasing doses. I'm not sure who volunteered for these tests, but they measured both the IL-8, the tumor necrotic factor, and procalcitonin, and found that the peak rates for the IL-8 reached peak levels at 4 hours, the tumor necrotic factor at 1.5 hours, and procalcitonin peaked at 24 hours. With that being said, this shows that again, that reiterates that procalcitonin is stimulated by the endotoxins. Other studies have shown that persistent or elevations is often indicates the advent or of an infection or sepsis in these situations. One study among burn patients, the mean procalcitonin on admission was found to be 1.4, peaking at 12.8, and among the non-surviving patients, the mean was higher at 4.6 on admission, with a peak of 86.8 the next day. With the most common cause of this mortality due to infectious etiology. So in sepsis, multiple studies have shown the benefit of differentiating SIRS from sepsis with relatively high sensitivities and specificities. Studies of patients with severe infection or sepsis, serum procalcitonin levels have varied over an enormous range. Some authors have stated that the threshold value of greater than 2 was strongly indicative of sepsis. Again, this is how they came up with the cutoff on that previous table. Many with severe bacterial infections was found to have serum levels of less than 2, and some patients did have levels of less than even 0.5, so it is not a 100% accurate marker by far. Again, other studies have shown that high initial procalcitonin levels in sepsis may have a poor prognostic implications, keeping in mind that some of the inciting factors that cause bacterial infections, such as mechanical trauma, surgeries, burns, can in itself cause elevations in procalcitonin levels. Low levels may indicate a better prognosis, and again, as my previous point, they did have cases where severe bacterial infections did have low levels. Authors recommended that serial measurements should be performed whenever possible to monitor the trends, with those that trended up having a poor prognostic indicator and also clinically showing a worsening of their underlying infection. With that being said, in some survivors, though, procalcitonin levels did actually decrease as their disease progressed. So what about non-bacterial infections? In a study, 236 cases of viral infections, only 3 patients had serum elevations of procalcitonin of greater than 2. Only 3 patients. Other studies have shown that viral infections, especially the ones that are systemic, have high values, even as high as 17. In studies with patients with invasive fungal infections, there had a tendency to have high procalcitonin levels, but not to the extent of bacterial infections. In one study, patients with invasive fungal infections comprised of 23 cases of aspergillosis and 21 cases of candidiasis. The procalcitonin was 0.69 on admission and 1.03 the next day, compared with 7.1 and 5.22 in those with bacterial infections. Again, so you have do have higher levels from baseline, but not to the extent of bacterial infections. For those with malarial infections, they often lead to very high procalcitonin levels, to the extent of even exceeding those of bacteria, with ranges that are variable, but levels of 662 have been reported in some cases. That's the cutoff for malaria. Okay. So how about cancer patients? Something we see with our Moffitt patients. And as I mentioned previously, that certain types of cancers, like medullary cancers, small cell, and neuroendocrine tumors, can in itself cause elevation of procalcitonin. So what is the utility in our cancer patient population? There's been several small studies that show procalcitonin concentrations can be used to discriminate between fevers of infectious and non-infectious origin in various types of cancer patients. And just focusing on one that was published in the CID in 2006, it looked at the utility of procalcitonin in the evaluation of patients with malignancy and elevated CRP. So basically, the procalcitonin concentrations was measured in 111 patients with hemato-oncological conditions with a CRP of 8. The population comprised of a mean age of 53, a female to male ratio of 50 to 61, and studied various types of cancers, including AML, which may comprise the majority, ALL, Hodgkin's lymphoma, non-Hodgkin's lymphoma, and solid tumors. Documented infection was identified in 42 patients. 30 had no signs of infection, and 39 patients had unexplained fever, which they clinically diagnosed this subgroup into 20 of them having fevers due to tumor and 8 due to medications. So they divided again into 4 groups: the infectious, non-infectious, tumor group, and drug group. So looking at the results, the top graph, looking at the procalcitonin concentrations, there was a statistically significant difference in, as indicated by the brackets, between the infectious group versus all the other subgroups, including non-infectious, drug group, and tumor group. Looking at the CRP plasma concentrations on the bottom graph, there was only a statistically significant difference in the infection group and drug group, but not necessarily in the infectious and non-infectious groups. So again, the results: procalcitonin were higher in patients with an infection than in patients without infection. And something I didn't mention is that it was in the normal range in the tumor and drug group, so a little bit more of a better test. Its conclusion was that procalcitonin concentrations contribute significantly to the differential diagnosis for elevated CRP concentrations in patients with oncologic conditions. So it can be used in cancer patients, is what essentially the study suggested. So what about CRP versus procalcitonin, which the previous study for the most part demonstrated? The majority of studies comparing procalcitonin with CRP have demonstrated that serum procalcitonin is more useful to monitor. One study showed that in contrast to CRP, procalcitonin was noted to be significantly higher in patients with bacterial infections. It was also noted to increase earlier, have a greater sensitivity, and correlate better with the clinical course. The authors of those papers concluded that the combination of procalcitonin and CRP would provide the most useful information. So how about procalcitonin and the severity of illness scoring? Several groups have examined the relationship between serum procalcitonin and the severity of illness scores, showing a moderate to fairly strong correlation. In a study of 33 patients with severe sepsis, 14 of who passed away, procalcitonin correlated with Apache 3 scores on all days and a simplified acute physiology scoring system on days 1 only. In another study involving 95 patients with sepsis in the SICU, though procalcitonin on mission did correlate with fatal outcomes, the Apache 2 and MOD scoring systems were better predictors. Something that, again, we deal with in antibiotic stewardship is using algorithms to somewhat decrease antibiotic exposure. This is a big study, and something I wanted to focus a little bit on is in that it was a major study that came out of JAMA in September 2009. It was called the ProHosp randomized control trial. A lot of our medicine colleagues have quoted this study, and as a result of this study, have used procalcitonin more extensively. The objective of that study was to examine whether a procalcitonin based algorithm can reduce antibiotic exposure without increasing the risk for serious adverse infections. It was a multi-center, non-inferiority randomized controlled trial in the emergency room of 6 tertiary care hospitals in Switzerland with an enrollment of 1,359 patients with mostly severe lower respiratory tract infections, which they define as community-acquired pneumonia, COPD exacerbation, and acute bronchitis, randomized between October of 2006 and March of 2008. So patients were again randomized to 2 arms, one being the administration of antibiotics based on procalcitonin algorithm with predefined cutoff ranges for initiating or stopping antibiotics or according to standard guidelines. The procalcitonin based algorithm included various cutoffs. At less than 0.1, the initiation continuation of antibiotics was strongly discouraged. At less than 0.5, antibiotics was discouraged, and at 0.25, the antibiotics were encouraged. If antibiotics were withheld, patients was clinically reevaluated, and repeat procalcitonin levels were obtained at 6 to 24 hours as per the previous guidelines. All hospitalized patients were reassessed at days 3, 5, 7, and at discharge. Procalcitonin were measured in the procalcitonin group at each of the interval days, and at each time point they reassess whether the antibiotics are continued or discontinued. For the outpatients, initiating and duration of antibiotic therapy was based solely on the initial procalcitonin levels. The primary non-inferiority endpoints of the study was within 30 days, death from any cause, ICU admission, disease-specific complication, and reoccurrence of the lower respiratory tract infections which needed antibiotic therapy. Secondary endpoints looked at antibiotic exposure, including the duration of therapy, adverse effects from antibiotic therapy, and the length of hospital stay. So going to the results, for the primary endpoint, a total of 103 patients in the procalcitonin algorithm group and 130 patients in the control group had adverse effects which were similar with a confidence interval of 95%. For the secondary endpoints, the mean duration of antibiotic exposure in procalcitonin versus the control group was lower in all patients, 5.7 days versus 8.7, with a 95 confidence interval. Antibiotic-associated adverse events, something that they didn't really go into detail, but it included nausea, diarrhea, and rash. But it did not comment on what other adverse events they took into account. Were less frequent in the procalcitonin group, 19.8% versus 28.1%. So looking again at the results, this shows the antibiotic exposure in patients receiving antibiotic therapy, with the black bar representing the procalcitonin and the lighter color bar representing the control. And in the top left, showed that in all patients there was less exposure. And then looking at each of the 3 subgroups of lower respiratory tract infections in the community-acquired pneumonia, the antibiotic exposure was again less compared to the standard, as well as in the exacerbation of the COPD and in the acute bronchitis. So the conclusion is that in patients with lower respiratory tract infections, a procalcitonin algorithm-based guidelines compared with standard guidelines resulted in similar rates of adverse outcomes with lower rates of antibiotic exposure and antibiotic-associated adverse events. So something that we may want to look into when we're dealing with the antibiotic stewardship. So that is it. In conclusion, procalcitonin is a biomarker of various clinical conditions, particularly sepsis and severe infections. Several studies report its usefulness in diagnosis, prognosis, and antibiotic stewardship, keeping in mind that not all elevated procalcitonin levels indicate a bacterial infection, and not all low procalcitonin levels exclude a severe bacterial infection. Procalcitonin results in conjunction with other laboratory results and clinical signs can be a valuable tool for clinicians, something that we can want to take away. So that is my references. I'll take any questions.